to where we were here. So the other main part of what we want to cover today is about the cardiac conduction system, or how the heart is electrically active and coordinates its activity. The heart's a little bit different, in cardiac muscle is a little bit different from skeletal muscle in that it's active on its own. The skeletal muscles that you studied back in A&P1 had to get an input from the nervous system. So there's that neuromuscular junction where the signal was coming from a nerve telling the muscle to contract. Cardiac muscle doesn't work that way. It's actually intrinsically active, which means that it generates its own signals. And those signals are propagated through the heart along what we call the cardiac conduction pathway, which is highlighted in this picture here. Now, I pointed out a little bit ago the SA node and the AV node, but for the sake of the models. But let me talk about them a little bit more. First off, SA stands for sinoatrial. It's in the right atrium, like I said. The sino part of that word refers to the fact that the right atrium can be considered a sinus. When we're talking about a sinus in regards to the circulatory system, that usually is referring to an enlargement in a vein. So commonly when you hear sinus, you think of the things in your head that get stuffed up with snot. But that's a space within a bone. In the circulatory system, a sinus is where a vein's expanded and there's a little extra space there. It's not always a vein, but it's usually a vein. And so the vena cava, which is a vein, the superior part that we can see here, and the inferior part, which isn't in the picture, but would be coming up from below, those basically expand into the right atrium. Now, there's no valve or anything separating a vein from an atrium. That's true on the right side here and also on the left side. But this is really kind of this little bulge coming off of the vena cava. So it's sometimes thought of as a sinus. And that's where sinoatrial comes from. And I explained earlier that AV means atrioventricular, between the atrium and the ventricles, and that's where the AV node is. Now, the SA node is responsible for setting the pace of the heart. It's referred to as the pacemaker. When you hear pacemaker, you usually think of a device that's been implanted in somebody. That's an artificial pacemaker. When the SA node doesn't work properly, an artificial pacemaker can be implanted with wires that will get into the tissue here and set up the conduction signal that we're about to describe, but doing it artificially. Now, like I was saying, the heart is intrinsically active, and it's intrinsically active because of these cells here. Over off to the side, we have a description of the action potentials that we see in these cells. Now, the numbers that you see on the side over here are not exactly the numbers that you're used to when we talk about action potentials, like -70 to +30 and those sorts of things. And that's just because the membranes of these cells don't operate on exactly the same voltages, but it's the same kind of idea. The action potential starts when the membrane potential hits threshold, and it rapidly rises up to a peak, which is because of sodium rushing into the cell. And then at the point where it hits the peak, sodium stops rushing in and potassium starts rushing out of the cell, which brings the membrane potential back down below threshold, which what you're used to would be when it gets back to resting potential. It's just these cells don't have a resting potential. They don't ever sit at a particular voltage for any amount of time. At the end of the action potential, when it's gotten to its lowest point, the membrane then starts to depolarize again, rather slowly. Once that depolarization hits the threshold level, things start happening very quickly again. Now, what's labeled as the pre-potential here, that spontaneous depolarization that's kind of slow, and the rapid depolarization, which is the rising phase of the action potential, both of those are because of sodium entering the cell. The difference in the rate is just in how much sodium is entering. And the way that we limit the amount of sodium entering to the cell is how many how many channels are open. During spontaneous depolarization, there are a small number of sodium channels that are open, and they're kind of always open. They're like leaking sodium into the cell. And so it's always gradually depolarizing. But when it hits threshold, that's when all of the voltage-gated sodium channels that you learned about last semester open up. And we get this very rapid depolarization from there. And then those cells are inactivated at the peak. The potassium channels open, potassium rushes out. And then when we get to the end of that and the potassium channels close again, that slow leak of sodium takes over again, and there's this pre-potential as it slowly goes back to threshold. The picture that we have here, the time course, they're basically saying the beginning of one action potential to the beginning of the next action potential is about 0.8 of a second. And that time course, we're going to see that a lot because that's the interval between heartbeats that we'd see for your average resting heart rate of about 75 beats per minute. If the heart's beating 60 beats per minute, that's once a second. That's going to be a full second between action potentials. Here, beating a little more than once a second, a little more than once a second, 0.8 is the standard length of time there. We can adjust the length of time between these by adjusting what's happening during this pre-potential. If less sodium enters in, the pre-potential will be slower. If more sodium enters in, it'll be shorter. Or alternately, we can hyperpolarize, which will counteract the depolarization. And there are a number of different ways to tweak exactly what's happening here and when things fire off. Do you have a question?
Yeah, so this pre-potential period is reestablishing the threshold or the resting membrane?
No, so there is no resting membrane potential. So a neuron or a skeletal muscle, its membrane will sit at negative 70 millivolts, roughly, until some stimulus from the outside acts on it and changes that membrane potential. These cells never have a resting membrane potential because there's always something moving across the membranes. Now, there's always something moving across a membrane at rest. It's just that it's an equal balance of positives moving in outweighing positives moving out. But here, there's always going to be this spontaneous depolarization, this sodium coming in. And once that depolarizes the membrane enough to hit threshold, that'll start the action potential. So it's not restoring threshold. Threshold is the point at which the action potential actually starts. This is just building up the threshold. And the faster we get it to build up the threshold, the faster the heartbeat is. The slower it reaches threshold, the slower the heartbeat is. And that's really what the autonomic system is doing. It's basically slowing down or speeding up the pre-potential period, which is going to affect heart rate. Okay. And the book goes into a little bit more detail on how it does that. But that's what these cells are doing. Okay. Now, the connections you see between the SA node and the AV node here, which are called internodal pathways, are just cells that are connected directly and will conduct that action potential from one node to the next. And then from the AV node, more cells conduct the action potentials along through what we call the AV bundle, which goes into the ventricular septum, and it splits into the right and left bundle branches, which then continue on down through the septum to the apex. And at the apex, they turn up on either side. Now, in a picture like this, it always kind of looks like they completely turn 180 degrees away from each other. But really what happens is, in 3 dimensions, all of the ventricular wall has these fibers going up into it. And at the end of those right and left bundle branches, there are Purkinje fibers, which connect to the rest of the muscle fibers so that everything there gets the signals that they're supposed to get. Now, these are all muscle cells. So the conduction pathway is made up of cardiac muscle cells, and the rest of the myocardium is made up of cardiac muscle cells. The difference is that the cells in the conduction pathway are specialized for conduction, and the other ones are specialized for contraction. So this is sort of like little electrical fibers within the myocardium, made up of the myocardium, which conduct the signals around. And there are connections from these specialized conducting fibers directly into the contractile fibers through intercalated discs and gap junctions and that sort of thing. The connections are very specific. The SA node connects to other cells in the atrial wall, not just in the internodal pathways, but really all of the atrial wall, all the way through to the other side. So both atria are directly connected into the SA node. When it fires off an action potential, that action potential propagates through all of both atrial walls. And with the action potential, you're going to get contraction of those muscles. The internodal pathways here, you don't always see represented in pictures of the cardiac conduction pathway because the AV node is also in the atrial wall. So it's going to be part of all of the wall that's getting the signal from the SA node. We don't necessarily have to point out that there are specialized cells there, but there are. So however it is, a signal propagates from the SA node to the AV node, and then from the AV node, the signal has to go through the AV bundle, the bundle branches, and the Purkinje fibers before it gets to the ventricular wall. Okay. The conduction through this area, especially at the AV node to AV bundle, is slowed down a little bit. The cells are thinner, and so propagation of the action potential is slowed down just enough so that the signal reaches the ventricular wall after the signal is spread throughout the atrial walls. You can see the top of a figure down at the bottom of the screen here, and I'm going to move there next. And it's just going to step through the process of what the cardiac conduction pathway does and how it affects the rest of the myocardium. Oh, right after we go here. So a little text slide here. So these are autorhythmic cells, which is what I was describing there a second ago, that they have this free potential which spontaneously depolarizes them to threshold, and they fire off another action potential all by themselves. They don't need any input from the outside world. The SA node will fire without any outside input at a rate of 100 beats per minute, right? Or 100 action potentials per minute, however you want to describe it. The AV node, and then also the fibers that make up the ventricular portion of the conduction pathway, also have an intrinsic rate of firing. If they do not get a signal from somewhere else, they'll fire at about 40 to 50 beats per minute or about 20 beats per minute. Now, they are getting a signal from the SA node. So when the SA node fires at 100 beats per minute, that signal is going to get to the AV node and cause it to fire at 100 beats per minute, and that's going to spread through the rest of the ventricular fibers at 100 beats per minute. So when the SA node's working, it sets the pace for everything. The other two intrinsic rates are really backups. If something happens, the SA node stops working, then the AV node can take over and set up a heart rate of about 40 to 50 beats per minute. Not a great heart rate, but it's enough for your body to kind of survive. Resting heart rate, like we said before, is about 75 beats per minute. Some people that are in really good shape will have a resting heart rate of maybe 60 beats per minute, but 40 to 50 is pretty low for a heart rate. But if somebody's heart is beating at that rate, it's enough to get blood around the body, get oxygen to the brain, get oxygen to the skeletal muscles that always have to work, like the diaphragm, that kind of thing. But it's not enough to satisfy oxygen requirements of any real exertion. if your heart is beating at 40 to 50 beats per minute, you're going to get tired just walking around, trying to walk up a flight of stairs, something like that.
Yeah, very good. The patient, you happen to be like a marathon runner, you have a resting heart rate 45 to 48. I mean, it's an outlier for sure. But
Right. Well, that again is somebody who's in good cardiovascular shape.
Right.
The heart rate is low because the cardiac muscle actually works better
Right,
than
it's
most
more
hearts. So there's a trade-off there. Yeah. So these numbers are kind of general averages. And what I'm saying is for a resting heart rate of 75, if your resting heart rate drops to 40 to 50 because your SA node is not working, that rate is enough for basic oxygen delivery throughout your body, but you will get exhausted doing what most people would think of as not a whole lot. Walking around, walking up a flight of stairs or something like that, you'll drop dead panting practically from it. Okay? But it's enough to get by. It's a backup measure if the SA node stops working. The ventricular fibers are yet another level of backup. Beating it at 20 beats per minute is not enough for the body to kind of get by at rest. It's not really enough to get enough oxygen up to the brain, even in terms of that orthostatic reflex we were talking about in the sympathetic system. That 20 beats per minute is not going to be enough to get blood up to the brain for people to just sit around and doing nothing. If your heart is working based just on the ventricular fibers firing at about 20 beats per minute, you better be laying down so that you're not working against gravity to get blood to your brain. And on top of that, you better be laying down in the back of an ambulance or at a hospital. Okay? When you're at that point, things are really pretty bad. But with intervention, it might be possible for you to get back to normal. It's not that when the SA node stops doing what it's supposed to do, that's it. You have a couple of layers of backup there. They're not optimal, but they are going to help keep things going around a little bit for the most part. But keep in mind, and this is often a sticking point for a lot of students, these rates that I talked about are only going to be in effect if the previous level is not working. So if the SA node works, you're going to fire off just normally. And that would be at about 100 beats per minute by itself, and your parasympathetic system actually slows that down for resting heart rate. But if the SA node is not working, then the AV node will take over, firing at a lower rate, but it's enough to get by for a little while. If that doesn't work and the SA node doesn't work, then the ventricular fibers will be the last line of defense. They don't work, your heart's not working, and it's just all over there. But that's how it's all set up. Then the rest of what's here is just sort of a walkthrough of the series of events that happen here. And what I want to do is actually do this in terms of the pictures that I have here. So the first thing that happens is the SA node depolarizes. Okay? It's hit threshold, it's generating an action potential. So we depict that with this purplish color here. And then from that, and this is at time 0, the very beginning of a heartbeat. From that, the depolarization spreads through the intercalated discs to all of the cells in both the atrial walls, spreading across. Eventually, that'll get to spread through both of the atria completely, which will include the AV node. Okay. Now, the purple here is representing the depolarization, and then they've also drawn it so you can see the walls of the atria are kind of collapsing in because it's contracting. We'll talk about contraction of these muscles in a little bit in more detail, but the contraction actually lasts for a while. Skeletal muscle contraction is fairly rapid, but because the action potential is fairly quick. But here, the action potential is actually spread out. It lasts for a little longer, and so contraction is sustained for a while. And for the atrial walls, that's about 100 milliseconds. So the atria depolarize and contract for about 1/10 of a second. And at the AV node and into the AV bundle, the conduction pathways thinned out so that the electricity moves, or the electrical signal moves slower, to delay the signal from going on into the ventricles until after that atrial contraction. And then after it's moved on into the bundle branches and it's going down the septum towards the apex, the atria have stopped their thing. They're done. And this is going to start to spread into the ventricular walls, which when they start to depolarize are also going to start to contract. So the atrial contractions are timed so that they come right before the ventricular contractions. Or the other way of saying that, the ventricular contractions are timed so they come right after the atrial contractions. So the atria contract and they release, and the ventricles contract and they release. And the atria and the ventricles, atria, ventricles, atria, ventricles, lub, dub, lub, dub, lub, dub. It's set up to time those two contractions perfectly. Now, I say set up like somebody sat down with, a computer program to time all of this. It's really just a matter of the conduction pathway slows down the signal a little bit there before it gets to the ventricles, so that the ventricles don't get the signal until at the same time as the atria have done their thing. And that kind of timing is set up just over the years. All of the organisms that have all had hearts that are controlled like this, the ones that have the most efficient hearts are going to survive and pass their genes on. And so the timing setup that I'm talking about is just inherent in the system because it's been sort of specialized and adapted over the years and millennia of how the systems adapted to the development of the system. Now, we can look at and measure the electrical activity in the heart to some degree using what's called the EKG, or the electrocardiogram. Now, first off, a word about the abbreviation. You can see right here, and in most other sources, it'll be abbreviated ECG. I call it the EKG. There's two reasons, actually, maybe it's three reasons that I do that. First off, I'm old and I don't have to change what I do. Okay. Now, while that's kind of a joke, it is to some degree true in a broader sense. As a student, you learn that, certain things have multiple names. And it's, at one time something was called such and such, and then it's changing over the years, but the older people don't change their way of referring to things, so the old name sticks around. And to some degree, that's part of what I'm doing. I get EKGs done all the time, and so I'm so used to referring to them, I've always called them EKG. Now, that's kind of the silly reason why I do it. The more important reason why I do it is because ECG, verbally spoken, which is kind of redundant to say, is easy to confuse with other tests that are similar. An EEG, an electroencephalogram, can be a point of confusion between ECG, electrocardiogram. So I stick with EKG because the K is a very obvious sound, and you can tell them apart. The reason why it's abbreviated EKG, or why it was originally, is the person that discovered this, who we'll find out about a little bit later on, he's Dutch, and back then in the early 1900s, pretty much the major focus of physiology was handled in Germanic states. So the de facto language for science having to do with physiology was German. And cardio in German starts with a K, so it's EKG. Nowadays, English is kind of the de facto language of science everywhere. And so the electrocardiogram is spelled with a C instead of a K. And so there's this movement to change the abbreviation to C to reflect the English spelling. But really, the original spelling and where the abbreviation EKG comes from is from the German. And so I prefer the K because, again, when I'm speaking, it's easier to hear the K than the C, and you don't get confused with the EEG or something like that. So up top here, we have a drawing of 4 heartbeats worth of recording of an EKG. They've drawn a box around 2 of them here in the middle, which are enlarged to show us what we're looking at. what's happening, and it's on a graph paper up there at the beginning, up at the top, what's happening is a pen on the graph paper moves up or down based on electrical changes that are recorded by the EKG machine. So it sits at 0 in the middle, and it can go up or it can go down based on the change in voltage. That particular graph paper isn't drawn exactly the way that you tend to see it if it's done actually on graph paper. The little boxes in there are 2/100ths of a second, I think. Is that right? No. I can't remember. I'm not going to do the math in my head right now. 5 of them in a row equals 2/10ths of a second. Okay. So divide that by 5. That's, what? 0.04. 0.04, okay. I was trying to say 2/200ths, 4/100ths. And 5 boxes top to bottom is 1/2 of a millivolt. So they don't have the big lines, the 5 by 5 boxes drawn in there, but in the lower picture, they do have over here a scale that's in millivolts. So at 0, there'd be the line that goes right along the baseline there. And then 5 boxes up would be 1/2 a millivolt, and 5 boxes down would be 1/2 a millivolt. And then also 5 boxes from this point over would be 2/10ths of a second, et cetera, et cetera. The reason I mention that is actually when you're looking at an EKG, when it's on graph paper like that, if you're trained in doing this, you can look at 2 heartbeats and say what rate those heartbeats are at. When they're 20 little boxes apart or 4 big boxes apart, that's a 0.8 seconds time frame. So if from this peak right here to this peak right here is 0.8 of a second, then we're talking about our normal resting heart rate. And that's the way this is drawn. So the pen moves up and down a little bit, depending on what little bit of electrical change there is. The first time it moves up for a heartbeat, we call that the P wave. There's a reason why it starts with P. I don't remember what it is, and I don't care. It starts with P. And then when it moves down next, it's Q, and then it moves up, it's R, and then it moves down, it's S, and then it stays flat for a little bit and moves up, and it's T. So each of those movements, up, down, up, are just P, Q, R, S, T. We really only talk about 3 things. The P wave by itself, the Q, R, and S waves collectively are referred to as the Qrs Complex. They happen so quickly together, we just sort of put them all together. And then the T wave. Each of these represents a specific event in what we just talked about there. The P wave is when we see the atria depolarizing. So that's going to be the peak of the P wave is when the purple was all the way across both the right and left atria. From that point where they're all depolarized, over for about 100 milliseconds, the cells are going to remain depolarized and they're going to contract. The trace that we see goes back down to 0. Not to say that the electricity has gone back down to 0 or the electrical charge has gone back down to 0, but rather that there's no change in the electrical signal. So it goes up, hits a peak, and stays there for a while. But really what we see on the EKG is there's a bump when it changes, and it goes back down to 0 when it's not changing. And then at 100 milliseconds, those cells are going to repolarize and go back to their resting or pre-potential levels. We don't see a specific event for that because it's covered up by the much more significant changes of the Qrs complex, which is when the ventricular walls are depolarized. And when we see the peak there, which is huge relatively speaking, that's because there's been this massive change in the voltage across a lot of myocardium. The amount of tissue in the atrial walls versus the amount of tissue in the ventricular walls is just staggeringly different. So we see a huge change here. And that change is so significant, we don't actually see any evidence of the atrial repolarization. It's kind of hidden behind that. And after the peak, those cells stay depolarized. The ventricles stay depolarized for like 250 to 300 milliseconds, usually 270 milliseconds is the time point. And that's really the time from the peak of the R to the peak of the T wave. And the T wave represents when the ventricles repolarize. So while on the trace here, we see it go up and down for the beginning of ventricular depolarization. And we see going up and down for the end of ventricular depolarization. If we were to look at the voltage across the membrane of those cells, it would go up, stay up for a while, then come back down. Okay. We're just looking at events where things change. They're staying the same between R and T, or between the Qrs complex and the T wave. So in between, we have this kind of zero flat line. Just nothing's changing right there. And then after the T wave, the cells have all gone back to their normal resting state. And so we have a flat line until we get to the next P wave. And then we have a Qrs complex. Then we have another flat line before the T wave. So we go through another heartbeat there. So as we're following along a trace, we see P, Qrs complex, T. P, Qrs complex, T. P, Qrs, T. P, Qrs, T. And it's just going to over and over do the same thing. Yeah.
That strip is an example of sinus rhythm.
Right. So this is a normal EKG. We call that a sinus rhythm because the SA node, the sinoatrial node, is in charge. So the P wave is the sinus doing what it's supposed to do. The Qrs complex shows that that signal has passed down through the AV node and the AV bundle to the bundle branches, and it plays out through the T wave. This is the normal situation we'd see. Now, the power of the EKG is that when we see something other than this, it actually tells us a lot about what's going on with the heart. So we can use it as a diagnostic tool to point out when there are problems. And that's one of the things I want to kind of talk about here. And before we go there, I want to talk about this, which is about action potentials in skeletal muscle versus cardiac muscle. So let me look at these pictures first. When you're learning about skeletal muscle action potentials, this is kind of what you saw. Okay, so we had a resting membrane potential, which this particular source is putting it -85. I usually teach it at -70, but the exact number doesn't matter. It's at rest until a stimulus comes along and causes the action potential, which goes up to its +30 peak and then right back down. It's a very quick event. That leads to a muscle twitch or contraction that we'd see like this. And here, this one we're looking at is about 50 or 75 milliseconds long, which is the sort of intermediate length of muscle contraction. There are some muscles that contract much quicker than that, like your eye muscles, and there are some muscles that contract much slower than that, like your postural muscles. But for your basic muscle, this is a pretty good muscle twitch curve. When we look at the cardiac muscle, it's a little bit different. So we have a resting potential, and then we have the depolarization going up to a peak. And then after the peak, it sits and sort of stays depolarized for a while before it repolarizes again. So compared to the action potential from the skeletal muscle or nervous tissue that you learned last semester, you have the rising phase and you have the falling phase, the sodium-dependent depolarization, the potassium-dependent repolarization. That's all there. What's different is what's in between. And that's what's called the plateau, okay, which we'll see in a second. But it's different, and if we look at how that action potential translates to contraction, we now get a much broader contraction curve. Now, just a word, this particular contraction curve really is applying to ventricular wall cells. We're looking at the atria, the contraction, the plateau and therefore the contraction would both be much shorter, about 100 milliseconds. But here, it's going out all the way practically to 300 milliseconds. Now, this picture kind of breaks down the cardiac muscle action potential a little bit. There's a rapid depolarization from sodium entry, gets up to a peak. The plateau is actually caused by calcium entry. Now, sodium is a positive charge and calcium is a positive charge, so they're both going to be related to depolarization. Just with calcium, it maintains that depolarization. It's plateaued, it keeps it up kind of high, and then after that, the repolarization is because calcium is leaving the cell and it goes back down to rest. Now, thinking back to skeletal muscle, what was calcium about in skeletal muscle?
Calcium was the stimulus for sodium influx.
No. Sodium influx is initiated at the neuromuscular junction through acetylcholine. Oh, you're talking about in the synapse. No. In the muscle cell, what's calcium do in the muscle cell for contraction? Yeah, it's the sarcoplasmic reticulum thing.
Yeah, I know there's a storage of calcium in sarcoplasmic reticulum. Carries a signal or just maintains? So
the muscle action potential spreads along the sarcolemma and down the T-tubules, where it then activates voltage-gated calcium channels in the sarcoplasmic reticulum. Calcium is released from the sarcoplasmic reticulum, diffuses into the cytoplasm or sarcoplasm, and it attaches to troponin. Troponin then moves tropomyosin out of the way, and myosin can bind to actin between the thick and thin filaments. Calcium is necessary for the sliding filament model to work. Okay, and the calcium comes from a storage site inside the cell, the sarcoplasmic reticulum. And as long as the calcium is in the cytoplasm, when it's outside the sarcoplasmic reticulum, that's when contraction takes place. In the cardiac muscle cell, the same thing's true, except that the plateau is when more calcium is allowed into the sarcoplasm, into the cytoplasm or sarcoplasm directly from outside. And as that sodium's coming in from outside, it's also going to keep the cell depolarized. Okay. So calcium's coming into the cell from outside during the plateau, and that calcium can then bind to troponin, tropomyosin moves out of the way, myosin and actin interact, and you get sliding movements. So there are sarcoplasmic reticula, I guess that's plural, in cardiac muscle cells too that store calcium, but there's also calcium coming in from outside. And since it's coming in from outside, it's going to affect the membrane voltage, and that's why we get the plateau. But that sustained calcium is why we have sustained contraction. It ties the two together there. So, okay, before we get into this, just to finish up the cardiac conduction stuff, I want to move to another source for a sec. Okay. Now, I am aware, like I usually am not, that we're here till 4:15 today, so I will probably use all that time. Okay, so in the heart folder, weekly folder, there's a link here to the Nobel Prize Electrocardiogram website. So this is a very similar website to what we looked at last week with the blood and the blood typing game. And in fact, if you want to go to the blood typing site, it's right there. But this one is on the electrocardiogram. Now, I've really not figured out why, but their web pages don't quite work correctly in Chrome or Firefox for that matter. But down here, kind of hidden white on white, is a link to an article, just like with the blood typing. And I just want to point out some things here. Actually, everything this says we've kind of already talked about. One thing that's kind of unfortunate, which I just discovered yesterday when I was doing this for my Wednesday morning lab, is right here. It says you need a flash player for this to work. And so I made sure I updated the flash player on this computer. Didn't make a difference. It's a little unfortunate because there was an animation there that apparently is dependent on flash that shows how this site animates the cardiac conduction pathway. So, and it's of a normal heart. So I can't show you that right now, but we're going to see the same sort of thing in a little while. It's just that the one I'm going to show you is actually from a heart that has a particular problem. If you happen to try this yourself at home or something like that, and your computer renders that animation itself, that's great. But for whatever reason, I can't get it to work on this computer. It goes on to talk about where electricity comes from and that sort of thing, which is about a lot of action potentials and membranes and positive ions moving in and out and all that kind of stuff, which you already know. It talks a little bit about the guy that won the prize. His name is Willem Einthoven. With the blood typing, I didn't mention the guy's name, but I'm mentioning this guy's name because his name is used in a second. Now, what he discovered was a way to reliably record very, very small changes in electricity at the level of the skin that reliably told us what was going on with the heart. So as I was talking about the graph paper a little bit earlier, those changes that we're seeing are happening in the scale of about a microvolt, like millivolt. Action potentials are happening on the scale of about 100 millivolts. And we're actually seeing electrical activity based on the changes across a whole bunch of cells. So there's a lot of electrical activity in the heart, but what we can actually measure at the level of the skin is a pretty small change. And he got the prize here because he found a way to do this very reliably. In here it tells that he uses a thing called a galvanometer. The electrical activity that we measure on the skin is the galvanic response. So he's doing that. It's the same technology as a lie detector test or something like that. But in fact, I mean, a lie detector test is just really a fancy EKG. And so it talks about electrodes, how you put those on the skin and you get the recording. What's new that I want to talk about here for a second is Einthoven's triangle. And this is why I mentioned his name, because it's this guy's name. The electrodes, which are suggested in this picture up here, and they don't show all of them. There's two more down in the ankles. There's one on the right arm, one on the left arm, one on the left leg. There's also one on the right leg, which is the grounding electrode to sort of subtract out the background electrical activity. But those three, right arm, left leg, define a triangle. And I've seen other representations of this that are a little bit more yeah, like this. Okay. Okay, this is kind of small, but what I was just talking about, the right arm electrode, which doesn't actually have to be on the wrist, it can be at the shoulder. The left arm electrode, again, doesn't have to be at the wrist, it can be at the shoulder. And the left leg electrode, which doesn't have to be on the ankle, it might be up at the hip, but whatever. That's drawing this little triangle around the chest, basically. And the heart is right in that. Now, I was kind of hoping to find a bigger picture. This might be good. All right, that's a really weird picture, but it makes the point I want to. This is how the heart is oriented within the chest. Of course, it's much larger than it should be. And then we see the triangle superimposed over it. The line that goes from the right arm to left leg here is essentially the same line that we would draw right through the heart from the apex to the base. Okay. And I'm pointing that out because the importance here of what they're talking about in Einthoven's triangle is that the three lines represent three different ways of recording or looking at the EKG. They're called leads. So up here, the leads in Einthoven's triangle, there are three leads that make up the three lines that make up the triangle. There's standard lead 1, which is right arm to left arm. standard lead 2, which is right arm to left leg, and standard lead 3, which is left arm to left leg. And there's a positive, negative directionality to those, which I don't want to get into right now. And standard lead 2, the right arm to left leg lead, is basically parallel to the axis of the heart. Okay? And I say that because when we're looking at the EKG, the thing I just showed you, the Qrs Complex and T waves, that shape is what we would record with standard lead 2. All of those events, P, Q, R, S, and T, are found however we record. It's just when we're looking at one of the other leads, they look different. So our point of reference in the standard way of talking about the EKG is based on standard lead 2. Down below, these 3 leads are called augmented leads, where all 3 of those points are compared together in different ways. And then there are 6 electrodes placed across the chest, which each represent a different lead. A lead is really when we're comparing 2 or more electrodes. And for the chest leads, or the precordial leads, it's basically comparing the chest electrode to ground and subtracting out the background. And that's going to give us pictures of what's happening electrically at the heart right there on top of it. Okay. Now we're going to pay most attention to lead 2, but I want you to know that other leads exist. And speaking of leads, it then shows us the trace, the P wave, QRS complex, and T wave. And then here it's getting at the idea that the EKG is a great tool to see when there's something wrong with the heart. If the heart beats weird, if the rate or the spacing between the peaks is off, we can see that pretty easily. And when there are conduction defects, when the conduction pathway isn't working properly, we'll see that in the EKG. So down here they have 2 pictures of hearts. The thing I couldn't show you, that animation that's not working because of it claims it doesn't have flash, was this kind of picture of a heart, but without a black spot for the dead tissue from a heart attack. And it showed the SA node right here flashing yellow, and then a line going from that to the AV node, and when the yellow line got to that, it flashed, and then the line continued down the AV bundle, and the bundle branches there. Just to sort of show you how it's depicting the same kind of thing. I wish I could show you the normal heart one, but for whatever reason it doesn't work. It doesn't work in Chrome, it doesn't work in Firefox, so I don't know what's going on. But we'll see one in a little while that's kind of like that. Here we see a heart that suffered a heart attack, and because of that, the tissue right here in the left ventricular wall is dead. A blood clot blocked a coronary artery, and oxygen didn't get to the muscle there, and when it's starved of oxygen, the muscle dies. Okay. So that black spot there represents dead tissue. Passing through that area there is the left bundle branch, and so that means that the conduction pathway doesn't work properly. This other one is similar. There's a little black spot right there. It's not necessarily because of a heart attack, but there's specifically a problem at the beginning, in this case, at the left bundle branch. And it's what we call a bundle branch block. So actually what I end up getting to show you for the animation is actually going to be this heart animated. So we're going to see what the heart looks like, the conduction pathway looks like when there's a left bundle branch block. Then he goes on to say a few things, which is really about how cells are electrically active, the pacemaker cells that I mentioned earlier, and changes in electricity, depolarization, repolarization. And then it ends saying this is an artificial pacemaker, which we don't really care about in this class right now. I mentioned it, but that's not the point of this. At the end, there is then an electrocardiogram game, which we can, we gotta go to from here. Now, this is sort of like the first-person shooter version of their games. Okay. Nobody? Nobody? All right. So you're the doctor, and you have in front of you a list of 4 patients that you're going to see. So let's start with Mr. Yellow, and when we push the intercom button, he shows up, and we know it's Mr. Yellow because he has a yellow tie. What we're now looking at is a piece of paper with a little bit of information about him, and down below is the dialogue we're about to have. So he says, I was referred to you by my doctor. I have to get an EKG. Is it going to hurt? And in your best bedside manner, you say, no, 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 it's not going to hurt. Take off all your clothes and lay down. Now, the Nobel Prize is administered out of, I'm pretty sure, Sweden. Actually, I'm saying that because, yes, it is out of Sweden, but there's some of the prizes that are actually administered in Norway somewhere. Whatever, it's a Scandinavian country. And I just want to warn you that Scandinavian countries, they have a different sort of outlook on life, and some things are more acceptable than what we would find. So don't be scared when I switch over here and he's wearing yellow Speedo underpants. Okay. So he is Mr. Yellow, so we can see he has yellow underpants. These are the 10 electrodes that we need to record the EKG, and you're going to place them. You hold the mouse over the electrode and it tells you where it goes. So this is the left arm electrode. Oops, you got to get it close to the wrist. And then this is the left ankle electrode, the right arm electrode, and then this is the right ankle electrode, which is also the grounding electrode. And then these 6 are all the chest electrodes. You don't have to place them perfectly. They would go, number 1 would go just to the right side of the sternum, and then 6 is around on the side adjacent to the heart. And they just sort of go across in order. You just have to hold them over the chest somewhere and they'll get placed where they're supposed to go. Okay. Like that. After you do your first patient, you do this properly. The next patient, you won't have to do this again. There will be a little button that says place electrodes or something like that for you to do it again. If you want to, you can place them manually, but you can just hit a button and it'll all go over. Once you have them placed, then the arrow button down here takes you to the recording. Now, this is going by kind of fast. Now, I want to talk about different things that we're looking at, and then I'll slow it down. So if we had seen the normal heart version of this earlier, you'd see what it's supposed to look like. But we have the SA node lighting up, the AV node lighting up when it gets this direct signal, and it goes into the AV bundle and the bundle branches. And the bundle branches go down to the apex and up the ventricular wall. Now, because of how this is drawn, they don't highlight Purkinje fibers separately. They're just part of what I'm pointing out as the bundle branch here. When the conduction pathway is doing its job, the myocardium is going to be depolarized and contract. And that's represented here by the flashing darker color. So when the atria all flash at once, that's it. It's depolarizing because of the SA node. And then as we follow the bundle branch down, we see flashing dark colors as it goes down towards the apex and up the wall there. And if we were looking at a normal heart, it would do the same thing on the other side. This is not a normal heart, so on the left side, we actually see the whole thing flashing at once. Okay. Now, this is going by very quickly. You can't really make sense of what any of this is showing. But with these buttons up here, we can look at different parts of the EKG. So right now, it's on the standard leads, 1, 2, and 3. You can switch to the augmented leads, or you can go through the 6 different precordial leads. And you can see that they all have some sort of PQRST sort of events going on, but they don't look the same. So this looks nothing like what we just saw. Or this looks kind of like what we just saw, but the P wave is almost non-existent. The Qrs complex is pretty sizable, that kind of thing. They're there, you just don't need to read them that way. You just read them from the standard lead 2. And this is going very, very fast, so we really don't want to look at it in real time. We can switch it to schematic. And with this, we now have arrow keys where we can direct the movement through. So you hit the arrow key once, you see the SA node light up, the atrial walls darken because they're depolarized, and with that, the depolarization spreads towards the AV node. And you see the P wave. Okay? So that's what's happened when the P wave has gone by. Hit the button again, we now see the conduction pathway progress through the AV bundle, AV node and bundle, and we don't see anything happening in the EKG because at that point, there's no big changes happening. It's just a flat line. What is happening, but not animated here, is the atrial walls are still depolarized and they're contracting. And that is going to end when we get into the Qrs complex, which starts here. And so we start the Qrs complex and we start to see it go down into the bundle branches. Now, in the pictures we saw earlier, the normal sinus rhythm, the Q is down, R is up, and the S is down. But here we don't quite see it that way. But this is the Qrs complex, even though there's not specifically a Q wave to it. And what's happening now is we've gotten through the AV bundle, and we're splitting into the bundle branches. And for this particular one, the right bundle branch is working just fine. The left bundle branch doesn't light up because there's a little spot there. That's that left bundle branch block that I showed you a second ago. And so as we start into the Qrs complex, the signals start to go down the septum, and then when they reach the apex and start to go up the wall, we start to see it climbing. It hasn't hit its peak yet because the depolarization hasn't spread throughout the entire thing yet. And so we get into the end of the bundle branch, and we hit the peak when it should have gotten all the way through. Now we see the left side flash darkly, suggesting that it's depolarized. What's happened is the connections from the right side to the left side have finally allowed the signal to spread over. It's just it's getting that signal a little late, and it's all contracting at once instead of starting at the apex and working its way up. Normally you start contracting the apex and work towards the the semilunar valves, kind of like squeezing toothpaste out of a toothpaste tube. You want to start at the end and push towards the opening. But with this bundle branch block, the left side doesn't quite work right. And if we keep going through here, after that depolarization is spread and when the left ventricle is contracting, the Qrs complex kind of falls off weird here at the end. It's a little broader at the base than it should be. And that's because the left side's a little bit behind everything else. And then it just plays out the rest. Nothing happens in the animation because they don't animate repolarization in this, but we repolarize the ventricles and we see the T wave. Okay. So that's what's happened in our guy. You can step back and forth through this with the arrows if you want to see everything happen. When you're happy with looking at this, you move on in the game and you go back to your office and you have the results from your patient. And then you have a book with reference EKGs to compare. There are 4 bookmarks, one that says blockage, one that says arrhythmia, one that says normal, healthy, and one that says cardiac infarction or heart attack. So you're basically taking 4 patients and figuring out which one of them corresponds to each of these conditions. Now we actually know our guy has a blockage because we saw the heart there. But if you go in here, you can actually establish that. So at each reference point, there are 2 pages, meaning 2 different references. So if you click on one, you see the first reference. And what you want to do is compare the reference to your guy. Now, just first glance, it's probably pretty obvious that this is not at all like our guy. What you want to do is look at the standard lead 2 and compare that. For our guy, we have that wide Qrs complex. The reference one here has a nice sharp peak that's pretty narrow at the base. So that's definitely different. But there's 2 references. We know our guy's a blockage, so it's not this type of blockage. It's a different type of blockage. So here we have another example, and this looks a lot more like our guy. Now, the Qrs complexes that we see here are not the same size as in the reference, and the size of those is a little temperamental sometimes. But more important is the shape. So if we look at the Qrs complex in our guy's lead 2 and compare it to the reference lead 2, the shape is very similar. It's got a nice broad base, and it falls off slowly compared to how it starts off. And then also just looking across the 2, there's a lot of similarities, especially down here in the precordial leads. 1 through 4 in our guy and 1 through 4 in the reference all have these rather deep spikes pointing down. And then 5 and 6 have smaller spikes pointing up. Okay, the shapes are similar. So just qualitatively, they look kind of similar. They look kind of similar. We know our guy has a blockage. We saw that in the specific animation we looked at. And we know it's not reference 1. They just don't look alike. So, but reference 2 looks pretty similar. And that's kind of similarity you're going to see. Then you click here to select the condition. We know he's got a blockage. We know actually he has a left bundle branch block, but they just give us as a choice a bundle branch block. So you click OK, and then you move on. And when you click to move on, you have the choice of calling another patient, going back to the list with the other 3 names, or you can quit the game and it'll show you your results. So for Mr. Yellow, who's the only one we did, we diagnosed him as having a blockage, and the green check mark means that we're correct. If there were a red X mark, that would mean that we were wrong. But of course, I'm not going to do it wrong just to show you a red X mark. But if you happen to do that, you'll see that. If you want to, you can print the results out, put it up on your refrigerator door or something like that, whatever. I don't need to see the results. Just like in the blood typing game, there's a question about the results from that game, the quiz. There's a question in the heart and EKG lab quiz about the results of this game. Okay. So you want to finish the other 3 patients and complete the game and answer the question about that. Now, Jen, I think you actually emailed me about this, but I used to have a link in here that said EKG examples. And if you had clicked on that link, it would have taken you to the box.com website saying there's nothing there, because I don't need that set of examples anymore. And I finally got around to erasing the link here, because in the book, where it goes on to talk about the cardiac conduction pathway, and this is essentially the same as the pictures I showed you a little bit ago, where the purple's spreading through the different areas. That's our book's version of that. And there's, whoops, the pre-potential type of membrane potential stuff we were talking about earlier, the comparison of the cardiac action potential with skeletal action potentials and the effect it has on contraction there. And then here it starts to talk about the EKG and describes the different parts. And it goes back to that same figure as before, but now it shows you where exactly in the EKG trace everything is to correspond to the different parts there. And then it has this everyday connection about abnormalities in EKG. So the book actually has a good example of some different types of EKGs. The top one here, this is normal sinus rhythm. Okay. The next one down is abnormal. We see QRS complexes, but we don't, they're not spaced equally apart like we would expect. So this is not a normal heart rhythm. And what you see, the smaller things where the P or the T wave would be, is a little bit confusing all over the place. What's happening here is that the signals from, wait a second. Oh, I'm sorry, that's right. This first one, I'm reading this a little backwards. The first one is not the sinus rhythm. The first one is the second degree or partial blockage. And here we see a P wave and there's no QRS complex after it. And if there's no QRS complex, there's no T wave. And then we see another P wave and it's a QRS complex. Then a T wave, then a P wave and no QRS complex and no T wave. Then P, QRS, T, P, QRS a little late there, but whatever. And so what this is showing is that not every P wave elicits a QRS complex. That's a second degree heart block or a partial heart block in the SA to AV node connection. Then this one, sorry, the label underneath it, atrial fibrillation, where the P and T waves are, it's just kind of confusing. And it's leading to generating QRS complexes, but at kind of very random times. And that's because there's like multiple SA nodes. That's what atrial fibrillation basically is. And so the QRS complexes are firing off kind of randomly because the same signal is not setting up the heartbeats. Then down here we have ventricular tachycardia, whereas we see a normal heartbeat to begin with, and then a train of heartbeats that are very abnormal looking because the ventricle is basically pacing itself and pacing it kind of fast. This kind of tachycardia might feel like your heart's racing and that sort of thing. It can lead into ventricular fibrillation, which is what's happening during a heart attack. So there's some different ones. And then down here we have a third-degree heart block, which I'm not that familiar with. But the third-degree heart block here, the Qrs complexes are quite far apart. And the heart rate here is at that 40 to 50 range. So while there are some things that look like P waves in here, they don't cause the Qrs complexes. There's a complete blockage from the SA node to the AV node. And so the Qrs complexes are initiated by the AV node at that 40 to 50 beats per minute. This is also known as a junctional rhythm. Okay, sinus rhythm is the SA node's in charge. A junctional rhythm is when the AV node's in charge because it's at the junction between the atrium and the ventricle. That's where the name comes from. But we see P waves, but they just don't actually precede the Qrs complexes. Qrs complexes are doing their own thing. So this stuff is a little bit described in here, but the handout that I used to have actually had all of these examples in it. It actually didn't have the tachycardia one in here, so it's kind of nice that's in here. Now, it goes on to talk about defibrillators. You've probably seen defibrillators in most medical dramas. Sometime there's going to be somebody that goes clear and shocks somebody out of a bad heart rhythm. That's a defibrillator. This is just talking about these automatic defibrillators, which it would be very nice if we happen to have them here. They're the kind of things that might be life-saving to somebody if they're around, but not having it here. If somebody goes into has a problem and we don't have a defibrillator, we might not be able to get to help them in time, and there'll be sorts of problems. And I'm actually personally kind of concerned about it because I have a heart condition where having one of these laying around would actually be helpful, but we don't, so there. Welcome to state schools. Anyway, so it sort of finishes talking about some of that stuff. But those are some examples of abnormal EKGs, which I used to have in the Blackboard thing, but now because the new book has them, I took that link out. Yeah.
Physically, what causes something like the lumbar branch block? If it's not ischemia or the heart attack or dead tissue, what else is?
It could be not exactly dead tissue, but scar tissue. For instance, I have a problem about that, which is probably from heart surgery I had as a kid. Or it could be, I don't actually have good data from before the surgery, so I don't know if it was there first. It could be from the original defect I had. So my heart didn't develop exactly correctly. And so it could be that in the conduction pathway, there's some problem with those cells, so they don't conduct electricity properly, something like that. But if you put me on an EKG machine now, and nowadays they're so automated, they spit out diagnoses, it'll say that I've got a right bundle branch block. I don't actually have a right bundle branch block. I have other problems with the right side of my heart, which present that way. But that might have been developmental, or it might actually be scar tissue from the heart surgery that I had as a kid. So those kinds of things could lead to it, besides a heart attack. Yeah.
I know someone who's like they have a heart condition where their heart will just randomly beat really fast, and for hers, she was in the hospital after she had a baby, and they gave her a shot of something to stop it a couple times. Why wouldn't they just shock her? Is that just if the heart stopped, if it's too low?
Well, you don't. Shocking somebody is a really horrible thing to do to them.
Yeah.
And actually, I read some articles. Well, yeah, it's going to make a lot of muscles contract, but it's not going to burn her chest. actually, I was reading an article that a lot of doctors will sign DNRs, do not resuscitate orders, because they don't want to be shocked like that. In medical dramas, they show that often people are saved by being shocked like that. But between shocking and chest compressions, the survival rate is really not that great. So a lot of doctors would rather not go through that. So they sign DNRs so that they're not shocked like that, because it can be helpful, but probably across all of the situations, it's not the best intervention. So for her, they might not have wanted a shock because it's not a great thing to do to the body in general. I don't know what drug they gave. It was probably epinephrine, which is, oh wait, no. So she had an elevated heart rate? Yeah, so epinephrine would be a bad idea there. Sorry? Right, okay. So yeah, defibrillator can help bring that back, but it's a rather significant thing. So I said epinephrine, which would be the exact wrong thing to do in that case, because that would just raise heart rate. So it's going to be probably a calcium channel blocker.
They actually give adenosine a lot. Well, most often, it's very short acting, but it's just so you can actually get an actual read of what rhythm that person's in. Because if it's that quick, it's hard to really establish what rhythm they're in because the complexes are so close together. And when given another proper dose of that, I mean, the lower level or lower rate can be sustained. Yeah, how
yeah. So I think adenosine is a channel, calcium channel blocker, but I'm not positive. And by doing that, by blocking that channel, calcium channels, that defeats the plateau, which is going to stop contractions. I don't know why it was painful. It could have been because it kind of throws the heart off and the heart just sort of goes, what the hell? Or it could be that calcium channel blockers are also going to block calcium channels in neurons. So there might have been some pain sensation, sort of a side effect of that drug.
They also use magnesium with drips too.
Right, magnesium is a calcium channel blocker. Magnesium is the element in the periodic table just below calcium. They both have a positive T charge. Excuse me, but it's a bigger ion, so it'll block a calcium channel. And so it's given as a drip sometimes for similar reasons. Okay. Other questions? Okay. So going back to the presentation, I just want to move through a few things quickly, which is a little bit unfair because it's kind of big stuff, but I just want to hit on a few things that are important to understand. Here we're looking at what's called the cardiac cycle. There we go. It's up there at the top. And the circle just represents what's happening over the course of a single heartbeat. What's happening is the atria contract, and then the ventricles contract, and then everything's relaxed. And then the atria contract, and the ventricles contract, and everything's relaxed. And when the atria contract, and the ventricles are relaxed, and when the ventricles contract, the atria are relaxed. Two words here that correspond to this, let me zoom in so we can see those words, are systole and diastole. Systole means contraction. So when the atria are contracted, we call that part of the cardiac cycle atrial systole. And when the atria are relaxed, which is the rest of the cycle here, we consider them being in diastole. When the ventricles contract, which is sort of the far side of the circle from where I'm standing, that's ventricular systole. And when they're relaxed, which is the rest of the circle there, they're in diastole. The two sets of chambers are not, don't overlap time-wise, and in fact, at 100 milliseconds, right here, atrial systole ends and ventricular systole starts. I was saying earlier that the timing from the conduction system lines that up kind of perfectly. So this is about when contraction pushes blood from the atria into the ventricles, and then contraction pushes blood from the ventricles into the arteries. And then when things are relaxed, the blood fills the atria and the ventricles, and then it all starts over again. The time points here, 0, 100, 370, and 800. The 800, again, that's the resting heart rate speed. The 100 and the 370 are kind of fixed points. That has to do with the contraction curves that I talked about a little bit ago. So contraction for an atrial myocardial cell is kind of fixed at 100 milliseconds. So atrial systole will always be 100 milliseconds long. And then ventricular systole is always going to be 270 milliseconds long. Okay. So this says 370 because that's 100 plus 270. Those values aren't going to change. If if the heart rate is going to be slower, then the relaxed period is going to be longer. So instead of 370 to 800, it could be 370 to 1,000 milliseconds for a heart rate of 60 beats per minute. And likewise, the other direction, if it's shorter, we're going to go through the 100 and 270 millisecond contraction times there, like always. And then the time between the end of that ventricular systole and the start of the next atrial systole is where we really adjust heart rate. So if the heart's beating at 130 beats per minute, I don't know the numbers exactly, but let's say that's going to slow it down, speed it up so much that the time point here at the end of this might be 550 milliseconds, something like that. So we just shorten this half of the cycle to adjust heart rate. So, oh, this stupid computer, come on. For some reason, this has been acting up on me. And if I just get out of the presentation, get back into it, it works. Now, this rather complex figure is basically breaking down what's happening during that cardiac cycle. So these two stripes here, which are labeled atrial systole, atrial diastole, ventricular diastole, ventricular systole, that's essentially what's in the center of the circle there, just laid out straight. And we see how the EKG events correspond to those different things. And then down below, we see how blood pressure changes and blood volume changes as we go through the cardiac cycle. Now, both of these are concentrating on the left side of the heart, because that's what we really care about, what's pumping the blood back to the body. The concepts are the same on the right side of the heart, but the numbers are different. The pressure numbers are different. Excuse me. The pressure numbers are different. The volume that we're looking at here is specifically in reference to the left ventricle. The right ventricle is going to be similar volume-wise because you got to have the same amount of blood moving through everything. But again, we're paying attention to the left side of the heart. We kind of walk through different points happening here. The red line represents the pressure in the ventricle, left ventricle. The blue line represents the pressure in the left atrium. And the black line represents the pressure in the aorta. And really what we're talking about here, what's driving the movement of blood through the heart, is just pressure differentials. So anytime that pressure is high, it's going to move, the blood is going to move to where the pressure is low. And the difference can be just a couple of millimeters of mercury worth of pressure. The thing is valves will keep things from moving from one place to another. Okay, so we're talking about 3 different locations, but blood is only moving from one to another to a second. The third one is always kind of blocked off by a valve somewhere. So to begin with, the atrial pressure is a little bit higher than the ventricular pressure, so blood moves from the atrium into the ventricles. Pressure builds up during atrial contraction, atrial systole, because of that contraction. And that's going to force the last little bit of blood into the ventricles. And as that happens, the ventricular pressure is going to go up too, because of the volume that's added there. When the two lines cross over, the pressure in the ventricle is higher than the pressure in the atrium, and it's going to push back against the valve and close the valve. And then the pressure in the ventricle rises very quickly because the ventricles start to contract. Once the pressure gets high enough that it's going to match the aortic pressure, it pushes the aortic valve open. So between this point right down here where the left AV valve closes, the mitral valve closes, and the aortic valve opens, all through there, both of those valves are closed, and no blood's moving, the pressure is just building up. If we look at the volume down here, it all corresponds. This is when the mitral valve closes, this is when the aortic valve opens, and the volume line is flat. There's no change in volume there. And then once the aortic valve opens, the blood moves out of the ventricle into the aorta, and so volume drops until we get to the point where the pressures cross back over and the aortic valve closes because the pressure in the aorta is higher and pushes it closed. And that's when the drop in volume ends right there. And then the pressure drops rapidly in the ventricles until it crosses back over atrial pressure. And so we have a flat volume line there because the volume's not changing. The aortic valve just closed. The AV valve, the mitral valve, still hasn't opened yet. So no change in volume here, just a change in pressure until they cross over and the mitral valve opens again and blood starts coming in from the atrium down into the ventricle until the next heartbeat where atrial systole causes the last little bit of that blood to be pushed out. Okay? So that kind of highlights how they work together. In the volume thing, the highest volume is called end diastolic volume. The lowest volume is called end systolic volume, which means at the end of ventricular diastole, right before it starts contracting, that's the volume. And at the end of systole, when it finishes contracting, that's the lowest volume. Okay. The difference between those two is what we call the stroke volume, or the amount of blood that's ejected out of the ventricle into the aorta, which is kind of defined, oh, stupid thing. I don't know why this is doing it to me. So that's kind of defined here. So stroke volume is the amount of blood in the ventricle during diastole, end diastolic volume, minus the amount of blood in the ventricle after it is contracted, end systolic volume, which means it's the blood that's ejected from that. And we calculate that SV equals EDV minus ESV. Kind of related to that is another important clinical data point called ejection fraction. And it's using these same numbers, but it's a little bit more standardized data point. So ejection fraction is the percent volume of blood ejected during ventricular systole. And it's calculated by ejection fraction equals, would it be stroke volume over end diastolic volume. Okay. And it's represented as percentage. So you'd calculate stroke volume like the book just said there. Let me put that up higher. And you divide that by end diastolic volume. That gives you your ejection fraction. Now, ejection fraction is a nice normalized way to look at cardiac function. How well the left ventricle pumps blood out into the aorta really defines how well your heart's working. Ejection fraction should be somewhere around 55 or 60%. When it's really low, and 35% is the diagnostic criteria. We call that congestive heart failure, where the heart's not pumping blood out well enough. I have congestive heart failure because of this defect I was born with. And my ejection fraction is, in fact, well, last time I was measured with an MRI, 33%. The other ejection fraction that I'm familiar with, which is getting to be a very old story now, is Dick Cheney. Back in 2004, right before the elections, or not, I guess it would be 2003. No, 2004. He suffered a series of heart attacks right there, like in September or something like that, maybe August. And so the news was talking about Cheney's ejection fraction. And so I learned that Cheney and I have basically the same ejection fraction. He has his ejection fraction because his left ventricle has been through several heart attacks. And so the myocardium is damaged and it can't pump as efficiently. My problem has to do with the defect I was born with. But to just look at stroke volume by itself, which is what the picture I just showed you there from the presentation shows, it's not a really good representation of cardiac function, the ejection or contraction of the left ventricle. My stroke volume might be 80 milliliters, and Cheney's stroke volume might be 70 milliliters or something like that. I don't know the exact numbers. But we have the same ejection fraction because it's normalized to, it's the percentage of the overall diastolic end diastolic volume. Okay, so it kind of works out there. Okay, so as far as the, what's this thing called? Presentation I've been going through, there's a little bit more to go into, which is about cardiac output, which is more about cardiac function, and how we regulate cardiac function, which is really how we regulate cardiac output. I obviously don't have time to get into that today, so I'm going to save that for next week. You have the book, you can read through it, you can work on that stuff. I would suggest do not submit the Part 4 assignment for the heart chapter until after next week. Yes, it will technically be late as far as the due date's concerned, but it's better for you to be sure to hear all of this and you know everything you need to for those. The Part 1, 2, and 3 things, yes, we haven't necessarily covered everything in those, but since you can take those over and over again, you can either use the blunt force trauma approach, whatever you know. Just doing them over and over again until you find a word that works. If you want to do that, or you can hold off on those, Part 3 thing also. So thank you for actually hanging on to the end of the real class meeting, and have a nice weekend. I'll see you guys next week.
I see you tomorrow.
Yes, I'll see you tomorrow.